So let's get started. We start today evening's program, and it's a pleasure indeed to have Dr. Daniel Schwartz, who will talk to us on slowing CKD progression today. Daniel, it's indeed a privilege to say that Daniel and me were colleagues at the University of Toronto, and a very, a wonderful clinician and a very nice person to be with. He has been involved in a lot of technological advances, and if you've heard of the QxMed, which I think you should look up, it was all started by Daniel. So Daniel is a clinical assistant professor at the University of British Columbia, as well as the medical director of the Frazer Health Home Dialysis Program. He received his training at the University of British Columbia and the University of Toronto, where I actually had a chance to work side by side. His clinical interests are focused on peritoneal dialysis, management of late-stage CKD, and interventional nephrology. As well, he has had keen interest in knowledge translation at point of care and the intersection of information technology with clinical medicine. There is a lot more actually behind these lines, but I think Daniel is a very humble person, and so wouldn't actually, give out that much of information. So that's up to him to tell us now. Thanks very much, Daniel, for being here. I know it's a busy schedule and a busy morning, which you've taken off from, and to be with us here. Thank you. Extremely grateful. Over to you, Daniel.
All right. Thank you so much for having me. If you do find that my voice cuts out, please let me know. I think we're having some local internet issues. I mentioned to Lloyd before we got started that we had a big snow last week, and I think some of the lines are a bit rough right now. But if there are any glitches, just let me know. I can reset my router. It really is a pleasure to present today. And yeah, Lloyd and I go way, way, way back. And I must say, I appreciate the introduction, and I have very, very fond memories of working with Lloyd quite a few years ago now. It's quite terrifying to think how time passes quickly. But what I wanted to focus on today is slowing CKD progression. And I must say, as Lloyd mentioned, I have a lot of interests, but over the last 5 years or so, my interests in research and practice has really started to focus very heavily on chronic kidney disease and slowing progression, mostly out of a recognition that, although transplant and home dialysis is interesting and it's exciting, I personally think it's the wrong focus. That moving upstream and focusing on prevention is probably key. And for those of you who know of or remember Dr. Oriopoulos, I think he had a lot of foresight in that many, many years ago, before he passed away, he started a conference in nephrology in Toronto, which was focused purely on prevention. And for me, that's, I don't know if I knew it at the time, but it really sowed a lot of the seeds, which has turned into my clinical focus going forward. So today we'll talk a little bit about slowing CKD progression, whether it's related to RAS blockade, SGLT2 inhibition, data about Finerenone, data from Empa-kidney. This audience likely knows quite a bit about this, and in some areas certainly probably more than me. But I want to try to focus on some clinical pearls, some of the newer data that's available, and maybe some hope for the future. Here are some disclosures which I'll make before I move on. And I'll start by talking a little bit about diabetes. By the way, if there are questions, Lloyd, maybe I can ask you to keep an eye on the chat. The way I have my screen set up, I can't actually see the questions popping up. So please feel free to interrupt me and pose questions, but I'll leave plenty of time at the end for questions. But when I look at the model of type 2 diabetes, I think a lot about, the three major pathways that contribute to CKD progression, whether that's hemodynamic, metabolic, or due to inflammation and fibrosis. And although I'm not a scientist, although I maybe used to be one, I think that what's clear is we've come a long way in some areas, certainly in the hemodynamic space, but still probably a lot of opportunity to look at other contributors to the progression of chronic kidney disease. And we know that CKD, and certainly diabetic CKD, is a big issue. Where I work, about 40 to 50% of people with diabetes will eventually develop some form of diabetic kidney disease. And in Canada, I hate to say this, where I practice, it's still the leading cause of new end-stage kidney disease, which is shocking. In that really, if you get diabetes today, arguably there's no reason to ever end up with end-stage kidneys, and yet it's still about 50% of our patients on renal replacement therapy are there because of diabetes. So it's pretty terrible, and it's not just about end-stage kidney disease. Also, mortality and cardiovascular disease is a huge problem in this population. And this heat map, which I know you have all seen many times, is one which I both love and hate. I love it because it's very rich, and I think it really reinforces how critically important it is to be checking and, in fact, monitoring urine protein levels. And certainly those in primary care, we know they highly recognize the importance of monitoring and checking for urine protein, but also reminds us that even if the GFR isn't too scary, your degree of proteinuria is such a powerful predictor of how you're going to do, such a powerful predictor. And so I think this is a reminder that the patients we think aren't too bad, maybe the patient with the GFR of over 60, but lots of protein, this is still a really big deal. These patients are at risk. And, again, I focus on a lot of Canadian data just because of where I work, but I think the data here is the same the world over. And for the longest time, again, with diabetic kidney disease, we focused predominantly on ensuring glycemic control, optimizing blood pressure to a target blood pressure 130/80, and getting patients on RAS block. And for the longest time, that's basically all we knew. And then I still remember it at U of T, probably around the time when Lloyd and I met, when IDNC and Renal came out. And this was probably 2001. And it was really game changing, because before that, we really honestly didn't know that type 2 diabetes with proteinuric CKD would benefit from RAS blockade. We surmised that, we guessed that, but finally we knew we could see relative risk reductions in the 16 to 20% range. And I think that was, the beginning of optimism in CKD. And then we went through a very big dry spell. And we also noticed that if you look at, for example, the Renal study, even though there was a significant risk reduction in those on RAS blockade, there was still a huge unmet need. And that even though patients in the intervention arm did better, they still had a very unacceptable rate of kidney outcomes. And we all know this. Our kidney patients get worse. They don't stabilize. And even though if you look at care for diabetics the world over, things improved a lot, the end-stage kidney disease improvements were the most modest. And so it just, I think, a call, we got to do more. And we did go through a huge dry spell for probably 20 years almost, with not much new, until SGLT2 inhibitors came on the scene. And I think this is one of those examples where sometimes in medicine, you need a little bit of luck. Luck is arguably how we found penicillin. Luck is how we find a lot of things. And I don't think any of us really, maybe Dave Cherney knew, and Lloyd will remember Dave well, who was studying SGLT2 way before it was sexy. But I think that none of us really expected that an SGLT2 inhibitor would become such an important part of what we do for CKD. And certainly in some of the original cardiovascular outcome trials, that essentially the FDA forced these companies to do to ensure cardiovascular safety in the wake of some pretty scary diabetes crises with medications which reduce sugars but caused harm. We found these pre-specified secondary endpoints that looked at kidney outcomes and saw, hey, wait a second, it looks like these agents may show some significant benefit. And this was borne out in Credence, which, for our group at least, was pretty exciting. We showed a very significant reduction in the primary outcome of end-stage kidney disease, doubling of serum creatinine or renal or CV death. And again, this isn't what anyone was expecting, but certainly very quickly changed a lot of what we do. Even in a very well-resourced place like Canada, we still had a difficulty accessing SGLT2 inhibitors. In fact, where I practice, it was only very recently that insurers would cover these medications. But certainly our practice shifted wildly as a result of the data coming out. And, we see numbers needed to treat with SGLT2 inhibitors, which are, I think, very acceptable, very in line with what we deem to be reasonable CKD care. And DAPA CKD, when it came out, I think really changed things, because what it did is it raised that question of what's the pathophysiologic advantage of an SGLT2 inhibitor in progressive CKD. And so, well, if it works for diabetes, it's probably going to work for non-diabetes. And those patients without diabetic kidney disease clearly also benefited. And this study, I think, was also quite remarkable. We saw, probably it's one of the most phenomenal relative risk reductions I've seen in CKD care, with this 39% relative risk reduction for a composite endpoint, which again, we think we all would agree is reasonable, giving us a number needed to treat of 19. And even at the level of all-cause mortality showed a significant risk reduction. And so these medications in this class really shifted nephrology practice for us so significantly. That being said, we still struggle with the challenges of knowledge translation. And even, many years now later, we still look at our rates of patients on combination ACE inhibitor or ARB plus an SGLT2 inhibitor and see that our rates are still far too low. But we know there's a lot we can do. And more recently, we saw the Empa-kidney trial come out. And I think this trial was an exciting one. I felt bad for the researchers. They had this great hypothesis that, although we've studied patients who are highly proteinuric, a lot of CKD patients don't have significant degrees of albuminuria. And so they sought to include patients with lesser degrees of proteinuria, and basically put them on background RAS blockade plus SGLT2 inhibitor, empagliflozin in this case, and look at an important primary outcome, which was progression of chronic kidney disease or death from cardiovascular cause. And, they did a pretty good job of enrolling patients who had, yes, some of them had more significant proteinuria, but a lot of them had lesser degrees of proteinuria, and less than a third were from diabetes. So this really was a study that looked at, I would say bread and butter nephrology practice. And once again, showed a significant reduction with a 28% relative risk reduction in that composite endpoint. So it's so wonderful to see when something is not just luck. It's not just one study in a small group that maybe is subject to publication bias or some other methodological flaws. These are all well done studies. So the hazard ratios for patients, are interesting to look at when you do subgroup analysis. So what it showed is that there seems to be benefit regardless of diabetic status, regardless of how advanced your CKD was. But one of the big outstanding questions, for me at least, from Empa-kidney was, is there really a benefit in patients who are non-albuminuric? And this, I think, is as much a clinepi question as a philosophical question. If you look at the subgroups, it was challenging to show a difference in patients with very low levels of proteinuria. Why? Well, there were just fewer endpoints. If you look at, and fewer patients as well, but, very few endpoints over the course of a, study that lasts 2 years. And we know this. Why are most studies enrolling patients who are highly proteinuric? Well, it enriches for bad outcomes. So you can show a difference quicker and more robustly. And when you have patients with lower degrees of proteinuria, we don't really expect them to benefit in the short term. And so I guess the question needs to be asked, and I don't know I have the answer, and I welcome your thoughts, is if the study was designed to be very, very inclusive of all these patients, is it valid to do post-hoc subgroup analyses, which are underpowered, which then raises into question whether that entire population would benefit? And I don't know the answer to that. What I do know is that, and I don't show the slides here, but I do know that if you look at slope of GFR data, which I didn't present, but we can look up, all groups showed a reduction in the decline in slope of GFR. And so that's, still to me, very hopeful that regardless of degree of proteinuria, you may well benefit from SGLT2 inhibition. Was this a study that only looked at non-albuminuric patients? And answered the question definitively, no. But in all comers who were included in this trial, it did seem that SGLT2 inhibition benefit a very, very large population of patients with CKD, regardless of diabetic status. And so I think this story has come, through very nicely, that we now have clearly a very strong pillar of care and that SGLT2 inhibition should play in the years to come a very, very important role in slowing the rate at which CKD progresses. I think it's also important to understand there are so many barriers to use of SGLT2 inhibitors that are not just about funding. Yes, cost is a barrier anywhere you are in the world, but I think one of the bigger barriers is actually things like clinical inertia or misperceptions of the data. And I see so many misconceptions and a lot of comments which are maybe not well substantiated. I think it's also really important clinicians understand that if you look at early data, when you put someone on an SGLT2 inhibitor, just like a RAS blocker, you see initial dip in GFR. That's expected. To me, that tells me the drug's working. The patient's taking their medicine. But long-term, you see GFR stabilization. And yet, a lot of doctors, when they see that initial dip, or patients, and they have access to their own data, they say, hey, what'd you do? You gave me this medicine. It's supposed to help my kidneys, but it made it worse. And I think it's really important that we reassure people that we're not working on fixing a number. We're working on reducing an endpoint over a long period of time. And again, we see this in the primary outcome studies like credence and DAPA CKD as well. And so I think that it's important that not only do we understand the science, but we understand the psychology of the clinicians and the patients we work with, and that seeing dips in GFR early can be enough to get people to decide to stop a medication that can be very effective. I think it's also important to remember that dips in GFR are common. Although about a third did not see this dipping phenomena, 41% saw a small dip, but almost a third saw a modest dip of 10 to 30% GFR. And very, very large declines of more than 30% were very, very rare. And so those patients who have marked decline in GFR almost certainly have something else going on, need to be worked up. But an up to 30% drop in GFR is common, and not a sign you should stop the drug, but rather a sign that they're on it, and that if the patients you look after perform just as well as the patients in these clinical trials, they stand to benefit regardless of the change in GFR in the short term. I think it's also important to remember that these patients, despite RAS blockade plus SGLT2 inhibitor, again, still have significant residual risk, right? The intervention arm in these trials, we still saw bad things happening to patients at, I would argue, an unacceptably high rate. And that's because we don't have a cure for progressive CKD. And really, just like many chronic diseases like heart failure, COPD, HIV, whatever these diseases are, attacking it on one front is not enough. We need to attack these diseases on multiple fronts. We need to attack it multiple pathophysiologic pathways if we're going to really help a large global population of patients with a really severe and debilitating chronic disease. And so I think this is a slide to remind you of that risk, not to be pessimist, but to be a realist. Like, this is a real issue. And for me, I became interested quite a long time ago in MR, mineralocorticoid receptor overactivation. And I've been interested in this probably since the late 1990s with the publication of the Rail study. And for those of you who remember, this was really the first study which looked at spironolactone in patients with advanced heart failure. And at the time, it seemed pretty crazy to think that you could give someone an MRA and hope to improve heart failure outcomes. And now it's obviously a standard of care in heart failure management. But the thought at the time was that perhaps MRAs could reduce cardiac fibrosis and reduce perhaps worsening heart failure outcomes and sudden cardiac death. And certainly that's been well established in multiple clinical trials. And for those of us who look at kidney biopsies from time to time, I think we all know that the final common pathway of all kidney disease is fibrosis, right? It's the one thing it's very easy to spot as a non-pathologist on a renal biopsy is advanced disease from scarring, glomerulosclerosis, and fibrosis. And so could this be a pathway which we could intervene on? Well, I certainly know that there's been many years of data for spironolactone in advanced diabetic kidney disease with high-grade proteinuria, but the data was very limited. It showed a reduction in proteinuria and probably nothing more. We didn't have outcome data. Why? Probably because no one was funding it, to be honest. But along comes Finerenone, which is a novel selective non-steroidal MRA that works differently than the steroidal MRAs that we know well. And I certainly became interested and volunteered to be one of the investigators who enrolled patients in both the Fidelio and Figaro trials. And I think the hope here was that this would be a medication which would be very selective, would avoid the sexual side effects of, say, a spironolactone, avoid the hyperkalemia that we see with MRAs, and hopefully have a significant impact on kidney outcomes. And this was a sister pair, if you will, of trials, which were, I think, brilliantly designed. That the Fidelio, which was primarily the kidney trial, and the Figaro, which was the cardiovascular trial, were designed as sort of mirror images of each other. And I think one of the geniuses, or part of the genius of how they were designed, was they were built in a way that they were set up to have a meta-analysis ready to roll at publication because of how patients were enrolled and data was collected. I think it's important to recognize that this study enrolled a very broad selection of patients. If you look back at that heat map I showed you earlier, these studies enrolled patients with a broad range of GFRs and a broad range of degrees of proteinuria. And again, it makes these trials hopefully very appropriate for the population that we see in clinical practice. Also important to remember that the fear of potassium was still there, and that patients could only be in this trial if they were on ACE/ARB, but still had control of their serum potassium. And the study was pretty simple. They had a run-in period, screening period, and were either put on 10 or 20 of Finerenone versus placebo, as well as background therapy. Unfortunately, at the time this trial enrolled, which was years ago, SGLT2 inhibitors were not yet standard of care. So the placebo arm was not necessarily on an SGLT2 inhibitor. I think less than 7% of patients were on an SGLT2. So that is a whole other discussion which we can get into, but certainly the endpoints they looked at were simple. In the Fidelio trial, it was a composite kidney endpoint, and the secondary endpoint was basically a composite cardiovascular endpoint. And the Figaro trial was basically the reverse. The composite endpoint that was primary was the CV endpoint, and they used the kidney definition of endpoints for their secondary endpoint. So really, they were very similar trials in methodology, but looked at different endpoints. So it became very methodologically and statistically robust and set themselves up very nicely for a very nice meta-analysis. And again, study design, pretty simple. Enrollment criteria were a broad range of GFRs and ACRs, with GFRs down to 25. Importantly, K had to be controlled at enrollment, and the trial was planned to last for about 5 years. And I remember when this was presented in 2020 at the ASN. It was an online ASN, as many of us recall. But I must admit, I kind of enjoyed it being online. It was easy to watch sessions when it was convenient. And what was, again, super exciting is we now had a trial which showed a significant 18% relative risk reduction, in line with the relative risk reduction we saw way back with IDNT and Renal. And again, is one of these trials a magic bullet? Is it a cure? No. But I think what we're seeing in chronic disease care is we fix these problems over many generations with multiple things to do for our patients. And it seems like this is yet another intervention which may well be very helpful. And time to heart failure or cardiac outcomes also significantly reduced in Fidelio. Was there a bump in potassium? Yes, there was. And I think this is important to remember, that in medicine, there's no free lunch, that patients did show an increase in potassium. So it's still something we need to watch out for. Although this MRA is different, it's not without potassium issues. And although it was rare to have to discontinue medication, it still happened. And although hospitalization was uncommon from adverse events, it still happened. Thankfully, no deaths from it. But I think it reminds us we need to be cautious, and we need to look back, I think, at the Rail study when it first got published. When it first came out, it was huge in that it was a remarkable and novel treatment for heart failure, and it led to a huge increase in spironolactone use, but also, as David Gerlink at the University of Toronto showed, a huge spike in hyperkalemic events leading to hospitalization. And so clinical trials are not like real practice, and certainly something that needs to be considered as we explore this new medicine. Fidelity, as I referred to earlier, was the pre-specified meta-analysis. And because the endpoints were basically identical and the data was all readily available, this was a meta-analysis which was very easy to do. And what they were able to show, not surprisingly, is their composite CV outcome was significantly reduced, mostly due to reduction in hospitalization for heart failure. I think another nice analysis was that the cardiovascular benefits of Finerenone were consistent regardless of your GFR, regardless of baseline urine ACR, and regardless of whether you were on a GLP-1 or an SGLT2. And so I think what we're seeing, to me, which is just so exciting, is given that our patients have so much comorbidity, kidney and heart, whether that's cardiovascular risk, cardiovascular events, heart failure, what we're seeing is this real, I think, convergence of therapy. That it's not like we need to pick or choose which disease do we want to help the most. It's increasingly starting to look like if you're doing a good job looking after cardiovascular risk, you're also doing a great job looking after kidney risk. And conversely, if you're doing a good job looking after kidney risk, you're doing a great job looking after cardiovascular risk. I should point out that heart failure patients were excluded from these trials simply because it would likely be unethical to enroll patients with significant heart failure given the known benefits of MRAs in that population. However, data is coming as to whether Finerenone specifically is an MRA which helps in heart failure. But nonetheless, I think what we're seeing is this evolving data set, which is just, I don't know, super exciting to me. If we look at kidney composite outcome of time to kidney failure, sustained 57% reduction in GFR from baseline to renal death, again, we showed a significant reduction in that composite endpoint in this meta-analysis. One of the things, I think a lot about, though, is potassium. I can tell you that off-label, I've been using spironolactone for many years in patients with highly proteinuric CKD, simply because I didn't know what else to offer them. I knew that their prognosis was very poor. I knew that the surrogate outcome of proteinuria was clearly reduced. I did not know if hard clinical endpoints would be reduced, but I personally, have a bias to action. I prefer to take bets and cautiously try things which I believe will be helpful, but also when I have equipoise and enroll in clinical trials. And so I did spend a lot of time prescribing spironolactone for highly proteinuric CKD. When I had the opportunity to enroll in Fidelity and Figaro, I took that opportunity. And now that that data is available, I am certainly trying to get patients on MRAs more aggressively, although certainly even in a well-resourced place like Canada, access because of drug costs is a persistent barrier. But it did give me a lot of experience using MRAs and CKD in patients who were already on RAS potassium, as you might imagine, has become, the bane of my existence and a lot of what I do. And so I am also very interested in whether and how we can control potassium while also offering good kidney and cardiovascular care. One of my personal pet peeves is when I hear people say, I would love to offer them good organ protective care, but I can't because of the risk of hyperkalemia or a history of hyperkalemia. And I would argue that with good care, including dietary counseling, support from a dietitian where possible, but also use some medicines to help control potassium, we shouldn't, or it should be very rare that we're limited in our ability to provide organ protective care with RAS blockade MRAs simply because of potassium. And the AMBER trial is a trial I like, published a little while ago. And it's not a kidney trial, it's a resistant hypertension trial, but I think the question it asks is whether patiromer would enable the persistent use of spironolactone, patiromer being one of the more novel potassium controlling agents, although frankly we use a lot of simple sodium polystyrene, but we do take advantage of the two newer agents where possible. But what I loved about the study is what it showed is it is pragmatic to get patients on an MRA when you want to use it, if you work to control their potassium. Was this a hard outcome trial? No, it was not. But I think what it tells us is that if we work hard to control potassium through multiple strategies, it's reasonable to think we could still get people on the therapy which they need and deserve. The Diamond study, was a real, I think, victim of COVID, in that it was really hoping to be yet another trial which showed whether we could get people with heart failure and hyperkalemia onto good ACE, ARB, ARNI plus an MRA, and use patiromer to control their potassium, but look at hard clinical endpoints. Unfortunately, they just couldn't get the study to the state they wanted to because of COVID, and they ended up having to adjust their primary endpoint to be much more modest. And although they were able to show they could safely use it, they were unable to complete the study to show that it improved clinical outcomes. So we are left with the question as to whether the strategy improves outcomes, but I think we do know that in patients who have an indication for both RAS blockade and an MRA, there are strategies that potentially can be utilized to allow us to achieve both ends, safe levels of potassium, but also good organ protection. Going forward, I'm really excited about the possibility of GLP-1s as well as tirzepatide. Semaglutide is being looked at in the FLOW study with a composite kidney endpoint, and certainly observational data raises a lot of hope that this may yet be another class of agents which might be helpful in slowing progression of chronic kidney disease. But we'll find out soon enough. But I really, really hope that we are entering an era where, like heart failure, like other chronic diseases, if we can get patients onto multimodal therapy that attacks multiple aspects of the pathophysiology of chronic kidney disease, we can in fact not just slow, but potentially even halt progression of chronic kidney disease. And I will say anecdotally, this is just anecdote, that in my own practice, as a clinician who's become, I would say, very aggressive about getting patients on disease-modifying therapy, I've seen my practice shift in a way that is very different. The last 5 years of my clinical practice have been just so different than the first 10. I am seeing patients with high-grade proteinuria doing better than ever. And again, this is anecdote, but I certainly believe that it's worth the time, and it is time, to get patients on lots of medicines and adjust their diet and still focus on things like smoking cessation and weight loss and exercise, blood pressure control, glycemic control, metabolic acidosis control, all these things which we know are important. It's work and it's time. But for me, I guess now that I'm about 15 years into post-fellowship practice, I have become disillusioned with the excitement of transplant and the acuity of dialysis and the procedural nature of PD, which I enjoy. And I would much rather spend my time preventing bad things from happening to people in the first place. And so that's resulted in a shift in what I do and where I focus and where I spend my time. And at this point, I'm going to pause and hopefully I've left enough time to have some good questions. I see that in the chat, there is a request for you to fill in a form for CPD purposes. I would ask that when you all have a moment, either now or at the end, please do click on that link in the chat and fill out that form for the organizers. At this point, I'll pause, and Lloyd, I don't know if you want to field the questions or if there's any questions people have.
Yeah. Thanks, Daniel. That's a form for CPD in Tanzania, so there's no problem. Thank you very much. This was a wonderful session, and you simplified the entire data and presented in a very comprehensive manner, and not going into the depth of the studies, but telling us what exactly each of this meant, especially the ACE-ARB, the SGLT2, and of course Dave Cherney, who was a fellow with us, who was one of the pioneers of SGLT2. This is wonderful actually to hear the MRA trials of Fidelio and Figaro, and of course the use of patromia in suppressing potassium, and when you're using RAS and MRA. So before long, I think let's open the room to questions. Dr. Bhima has a question. Dr. Rajendra Bhima, Professor Bhima is from South Africa. Yes, Dr. Bhima, please go ahead.
Hi, thank you very much for that really great talk. It was really wonderful. Just that you took all my thunder away because I was supposed to give this talk for kids. But anyway, I'm just going to ask a bit of a ridiculous question because I was just wondering while you were talking, SGLT2 inhibitors and Finerenone work on proteinuric patients, and that's where the best outcome is. Am I right? So the thing is, has anyone tried this in nephrotics to see if it's any useful for decreasing proteinuria like ACE inhibitors?
Yeah, it's a good question. The short answer is I'm not aware that Finerenone has been looked at in nephrotic syndrome, although I would argue that the rationale for Finerenone is slowing fibrosis. And in nephrotic syndrome, the early problems of nephrotic syndrome are generally autoimmune, inflammatory at the glomerular level. And obviously late, we see lots of patients with late membranous, for example, which have advanced fibrosis. But I don't pretend to be a scientist, but I would be I would be suspicious that these drugs, because they don't have the hemodynamic effect that ACE inhibitors do, I would be very suspicious that they'd be that helpful in nephrotic syndrome itself. But that's more just speculating. I noticed there's actually a question in the chat, which I just saw, asking at what percentage EGFR dip would you consider withholding an SGLT2 inhibitor? Maybe that's okay. I'll address that question. For me, I am generally very hesitant to stop an SGLT2 inhibitor outside of an acute intercurrent illness with hypovolemia, sepsis, etc. And the reason for that is twofold. Number one, I think the data is very clear. SGLT2 inhibitors do not increase the risk of hyperkalemia or of acute kidney injury. In fact, the data has become very clear. These patients have less acute kidney injury. Why? I'm not sure, but that's the truth. And I think there is this myth that has been perpetuated that SGLT2 inhibitors increase AKI. That is not true. We need to stop that myth. Secondarily, I think there's a signaling component here, is that when people see us stopping a drug, they're left with the impression, oh, that drug is dangerous, that drug is hard to prescribe, that drug is hard to use, it's fraught with problems. And so I think we forget that as the nephrologist, our actions are heard, and our actions are very impactful and very powerful. And so if we stop it, other people say, oh, well, Dr. So-and-so stopped it, so there must be a problem with that medicine. Now, listen, I'm not a fool. If someone comes into hospital and they have, a virus and they're vomiting and they're having diarrhea for days and they're markedly hypovolemic, absolutely, I'll stop their SGLT2, I'll stop their ACE inhibitor, and we'll get them better. But I'll be very sure that by the time they leave hospital, I write a clear instruction to restart these agents. If you look at the data out there, dips of up to 30% upon initiation of the drug are commonplace. So I don't even repeat the GFR within the first few weeks of starting one of these agents. I usually monitor, for me at least, labs, every 3 months or so. If I see a modest dip, I just say, I'm a long-term thinker. I'm here to protect your organ over the long term. Now, if there's an acute, significant, striking drop, I work them up. I say, what happened to you? Are you obstructed? Do you have sepsis? Do you have a new disease? Are you taking anti-inflammatories or something like that? So I think the message needs to be really clear that we are leaders. People look to us, and we need to be very cautious about what our prescribing patterns do in terms of how other people perceive this class of agents. So although I will do it, obviously, if it is required, I think the data is clear. Dips are common. up to 30% is common, and AKI is reduced by SGLT2 inhibitors. So those are my comments on that.
Thank you, Daniel. Dr. Kajuru, any comments?
Thank you very much, Lloyd, and thank you very much, Daniel Schwartz, for the quite interesting topic. Now, did you make the formula for the pediatric EGFR calculation?
I think what you're referring to is the Calculate app by QxMD. So if you look on that app, there are hundreds and hundreds of clinical prediction tools, calculations, formulas. I did not make any of these formulas. The Schwartz who was involved is a different Schwartz who I've never met. I'd love to meet them sometime when maybe we're related. But no, I did not contribute to that. For me, yeah.
That was going to be a light moment. Now, obviously, from Africa, I find this topic very, very, very relevant for us. I guess everywhere, in view of the fact that dialysis, transplant, and everything else, even care for heart conditions and all those, it's so expensive and probably not very accessible to us. And I feel that as if the move towards getting all these drugs easily available here is too slow. But anyway, so do you know of any studies showing cost effectiveness in terms of helping to advocate this? That is one question, and I like the your discussion in terms of ACE inhibitor, not being afraid of it, with being able to manage potassium. But again, things like papilloma here are still quite rare, and the other scare we have, particularly in areas where the staple food is actually banana. We consume a lot of bananas in terms of like 5-6 bananas in a meal. So it becomes quite also challenging. So having a drug like papilloma would be very nice. Now, if I get it right, most of these trials in SGLT2 have patients who are already well optimized on ACE inhibitor or ARB. Now, in the case we chicken out using the ARB's ACE inhibitor, because now we can go down up to an EGFR of 20 with the SGLT inhibitors. What do you think the effect is? Because I have a feeling that the effect is combined with both an ARB and an SGLT inhibitor.
So there's a few questions there. So let me take one thing first about the issue of dietary potassium intake. So I think a lot of us, myself included, have this mindset that dietary potassium is a huge problem. And in fact, I just actually went to a really interesting rounds that's put on province-wide in British Columbia where I practice. We do an online rounds, which I think anyone can join if they like. But there was really interesting data presented that suggests that the dietary potassium we take has a very different impact on serum potassium than the potassium which is added as an additive to foods. And so that natural sources of potassium may in fact be far safer than dietary additives. And certainly in Canada, the diet here is different, and most of our potassium comes through dietary supplementation. So foods that have potassium added in the manufacturing process rather than through natural food sources. So I think it is raising some question that is this dogma, the dietary potassium, is it really that bad? So that's one comment. There was another question about cost effectiveness. And I would say that for SGLT2 inhibitors, it really depends on how you do these analyses, but certainly there is an argument depending on cost of therapy that these drugs are very cost effective. Finerenone is so novel. And as far as I know, the pricing is still very, very high. I have not seen a published cost effectiveness analysis, but I have seen a non-public analysis, certainly in Canada by CADA, which is the organization which looks at these things, and they raise concerns about cost effectiveness at the pricing which is being proposed in Canada. But I think on a more philosophical level, the way I look at these things is it doesn't matter where you are in the world, whether you're in a less resource location or a highly resourced location, cost and access to therapy is always an issue. In Canada, where we have a lot of drug plans, a lot of coverage for drugs, I still, all day, every day, struggle to get my patients onto therapy because of cost. And it is very frustrating. However, I also look at, the world in terms of generations, that although this research and patents leave drugs very, very costly for a period of time, that time is finite. And very quickly, drug costs come way, way, way down as patent life expires. And so although in the short term, it is, I think, very frustrating to struggle to get patients onto good care, I think what we should also remember is that the science is going to leave us for generations to come with knowledge which can be used. Is it frustrating that it's maybe too late for the patient sitting in front of you? Yeah, absolutely. But that is one thing that gives me some pause or some thought. And I guess the last question was about, ACE plus SGLT2. I don't know the answer to this, except that I know that the studies we see all use RAS blockade as background therapy. And so if you use, RAS blockade, or if you don't use RAS blockade, you just use an SGLT2 inhibitor, will you still see the same benefits? Hard to know, but certainly I think some subgroup analyses suggest that there's still benefit even in the absence of that RAS blockade. That being said, for many of our patients, in fact, for a lot of the patients we see in nephrology, you really do need multiple therapies if you're going to work away at all that risk, that residual risk that the patients struggle with.
I was just thanking him for the elaborate response, and maybe I should ask you, Lloyd, when do you stop the ACE inhibitor? At what GFR? Or how many mils of urine do you stop?
I wouldn't stop the ACE inhibitors as long as there is no hyperkalemia. If there is hyperkalemia, yes, it's a persistent problem. And if you're seeing a patient who is close to you or on follow-up with you, yes, I would not stop. I would actually treat. And if you have drugs to actually take care of the potassium, that is wonderful.
And just to add to that,
yeah.
Sorry, I completely agree with your point, Lloyd. And I think that if you again look at the SGLT2 trials, they continue these drugs all the way down to dialysis. And if you look at the RAS blockade data, we have a benazepril trial in stage 4 chronic kidney disease, which was published like over 20 years ago, which shows that in basically that the more advanced your CKD is, the larger absolute risk reduction you have in terms of slowing progression. And so if you have a patient with a GFR of 13 and high-grade proteinuria, and let's say they're not due to start dialysis until their GFR at 6, a RAS blockade will still slow that time period. And so my sense is that I do not stop ACE inhibitor, ARB, or SGLT2 inhibitor unless they become symptomatically uremic or develop intolerable side effects like hypotension or refractory hyperkalemia. But I do believe that even if you can delay or drag out the need for renal replacement therapy by initial 6 months, for a person, that's huge. So it's worth doing.
Yeah, and I think for people who are have more interstitial disease, particularly with HIV patients, some of them are actually potassium losing it, and I've had experience of keeping them on ACE inhibitors for quite a long time with a GFR below 15 while monitoring the potassium. At least that's the I've been comfortable with it. Now, of course, there's other variables with being brave, particularly with disappearing patients, being unable to monitor the potassium. But I do agree with the idea of until the last drop of urine. Thank you very much. This is very nice.
No problem. There's another question in here which I thought I might address. The question was asking about the reported case of osmotic nephrosis induced by SGLT2. And so I think that's actually something we need to consider. In patients who are very hyperglycemic, and again, in my practice, I don't see a lot of people with relatively preserved kidney function. So I actually don't see patients that often who can get an osmotic response to an SGLT2 simply because their GFR is less than 30. But in patients with more preserved GFR who are highly hyperglycemic, absolutely their SGLT2 inhibitor can induce a significant osmotic diuresis. And so we do have to be careful. And yes, that can cause an AKI. So I'm not saying these drugs can't do it. It's just they're actually protective overall. I think it's also important to remember that the risk of a DKA in diabetics on these drugs, particularly under situations of physiologic stress like surgery, is a very real phenomenon. And we've taken to basically stopping these drugs at least a week prior to major surgery to avoid some of that risk. So like all drugs, there's considerations about safety, and again, not a reason not to use them, but just a reason to use them more safely.
Thank you, Daniel.
There's also another question,
yeah,
maybe one last question about drugs on failing grafts. And I'll just say, with some frustration, these patients with kidney transplants are often excluded from these trials. I think from the SGLT2 inhibitor data set, I think there was this, I believe, unfounded fear that, you induce glucosuria, you'll cause UTI and pyelonephritis in transplants. UTI is not more common with SGLT2s. Yeast infections are, genital yeast infections are, but UTI is not consistently higher. So I'm frustrated these patients were not included. So we do have a lack of data there.
We've gone over time, and Daniel, I'm taking you off your very busy schedule. Extremely grateful for this wonderful session and a lot of interaction and a lot of good questions. Thanks to everyone who asked questions, and it was a lot of learning for all of us. Daniel, thank you very, very much, and we hope to see you more often for sure. I won't trouble you very frequently, but I need to see you at least once in 6 months to a year, please, 1 hour for us out this side.
All right, I would love to. Thanks for having me. Have a wonderful day, everyone.